Good evening, everyone. We will have James Seberger tonight talk about COVID and the effects of long COVID. So he's really been working on this, doing a lot of research. He's attended a lot of meetings. I'm sure he'll share some of that experience with everyone. But just so that you know a little bit about his background, he obtained both his Ph.D. and M.D. from the University of Nebraska Medical Center, completing his Ph.D. in biochemistry and molecular biology in 1999 and his M.D. in 2003. He then moved to Wichita, Kansas, where he finished his residency in family medicine in 2003. He opened his private practice in 2012 and continues to practice emergency medicine in the hospital setting as well. He works with me, his wife, at Performance Health, where he is a family medicine practitioner. His family medicine practice employs many types of modalities: medicine, vitamin supplementation, and neurofeedback. He quotes, "I try to have as many tools in my toolbox as I can. Sometimes patients are maxed out on different types of medicine and need additional means to control their blood pressure and their glucose down. I try to identify the root problem so I can directly address it. My goal is to recalibrate the patient, so to speak, and to stop any decline that may be occurring. From there, we focus on improving their health and to really help them feel better and perform better." So with that, I pass it over to James Seberger, who will be happily to talk about COVID and his PowerPoint that he will present to you now.
This is a PowerPoint that was half put together probably 2 months ago, and then new information came out in the last couple of months, and it went to really a very interesting direction. It's pretty important. What I really, we're cognitive folks, and we're dealing with brain, and we're dealing with real people, and we're on the front line of that. And we've just had really a massive pandemic. That's 4 years. It seems really a long time ago that the world was shut down. But we, at least in my city, in my part of the country, it seems as if people are sort of, like, okay, that was long ago, and things don't matter. But the problem is we're having something called long COVID, or post-COVID condition, or post-COVID syndrome, with really a lot of people being affected. And there's a lot of nebulous symptomology that we're seeing, and we're really, it really helps us if we can put a finger on what changes we're seeing, at least, and give an explanation or try to understand what's behind it. And so in this presentation, I really wanted to do that. I wanted to review the literature on some of the cognitive effects that are clearly in the literature, particular emphasis on neuroimaging, and then what may be causing that. I was thinking maybe after this, and you can tell me what you think. I think there's probably another talk with some of the other changes, and then particularly remedies and ways that we can help people. But to begin with, some of the most really interesting and frightening literature that's out there is looking at the MRI scans pre and post COVID infection. In the UK, they had really kind of an MRI brain bank, and they were able to do just that, compare MRI scans before and after COVID. And this was about at 90 days or so. And what these scans show, and this is by Dowd et al., and most of these references are actually from Nature and large publications. But they showed a clear reduction in gray matter thickness and tissue contrast in the orbital frontal cortex and perihippal gyrus and anterior cingulate gyrus, and the changes in markers of tissue damage in regions that are functionally connected to the primary olfactory cortex. And they do show an overall reduction in global brain size in the SARS-CoV-2 cases. And here's some of that image. You can clearly see the um, changes in voxel and standard deviations in these MRI images. And you can see the frontal regions clearly. You can also see the temporal regions as well. Next. In this same report, they were showing changes in trail making, and there really was a change in significance really beginning around age 55. So you know, it just persisted and grew as people were older taking this test. Next. And here's really something that most people have seen and know about, that there are changes in metabolism. This is a PET scan looking at low metabolic activity, and clearly it's affecting the brain stem, and you can see the right temporal region as well, and parts of the cerebellum and the crux. Next. So these are changes in thinking and cognitive function, but what about sort of frank pathology, frank disease? And this came out several years ago. It was a very, very large review of Veterans Affairs in like the 80s of thousands of records. And what they were able to do sort of by computer mining and testing is demonstrate relative risk and what happened in terms of disease processes. And clearly there was increased risks of dementia, psychotic disorders, seizures, even at 2 years post-infection. And what's really critical too is, sometimes a paraphrase sums it up. If people were going to get dementia at 70, and they were 65, they were getting dementia at 66. It was really a true acceleration of pathology. In my own circle last year, I was on a kind of shared a conference call with Senator Marshall, our U.S. Senator, one of our U.S. Senators from Kansas, and he said by 2028, the costs for dementia are going to outstrip all the costs of everything else that CMS is paying for. So it's quite stark. Next. Now, this is also really pretty darn new literature that came out just this year. And these are, these last slides were looking at sort of accelerated aging, accelerated pathology in older people. And in this case here, we have 270 patients who had long COVID, and they were divided between post-COVID patients without long COVID symptoms and those with symptoms, and uninfected individuals, control groups. And they really did kind of cognitive testing tasks. And they clearly saw cognitive slowing on 30-second task measuring simple reaction time, which was a 3 standard deviation from the healthy controls. And cognitive slowing on simple reaction time was highly correlated with the poor performance on a number of vigilant tests. They really pounded the data for comorbidities to see if there was any confounders, depression, anxiety, and they showed that these were independent. Next. And here's some of that data. The PCC stands for post-COVID condition. The PCC Ox stands for Oxford. And so they were looking at the reaction time and clearly saw changes in reaction time with the post-COVID condition. Next. And here is also some of that same data. Notice the bar graphs, and the pie graphs, they separated really the degree of impairment to really show that there was actually some impairment seen if you had infection in the no post-COVID condition. So it suggests that there's some unaware underlying deficit that exists because the severe impairment in the no COVID condition went from 4% to 19%. And the people who reported symptomology were in the 53% in terms of reaction time. So it's pretty impressive what they detected in this group. Next. And then similar results looking at number of vigilance tests. Again, you have pie graphs showing the data with the average mean, and you can see people who weren't aware of that they had a condition still measurably had really a threefold increase in severe impairment. The other problem in the bottom part, minutes in the number of vigilant tests, you can clearly see in the post-COVID condition and the no post-COVID condition, really reductions in accuracy doing this test. So we're really seeing functional problems. Next slide. And remarkably, I had just shown you that age was a factor in terms of psychiatric aging morbidities, but these were really young people. These were young people in their teens and early 20s. 85% of these were women, which really has a profound statement about function. And I'll mention it here. I think I have a slide on this in the future coming up, but we may be needing to differentiate two reasons for causes of what's happening. One may be in older people, simply damage, injury. In younger people, we are probably dealing with an autoimmune type component. Next slide. So positive correlations were observed between age and performance. Younger age showed worse performance, with older age showing improved performance. Really not what you would expect from a damage hypothesis. Also found improvements on testing with cognitive reserve, which you kind of would expect. And a significant positive correlation was found with verbal learning, immediate memory, and delayed memory, and implying that the longer the disease course, the better scores on these tests. Pretty interesting how these numbers worked out. Okay, so again, there's a difference in pathology between young and old, and that implies different mechanisms of injury. So what do we see in the QEEG? So there's not huge amounts of data. These are from early studies, and the QEEG looked at patients really coming out of the ICU, and they compared that to toxic encephalopathy and post-cardiac respiratory arrest encephalopathy. And this group, about 20 people in each group, got Qs before and after, and they clearly showed changes in the EEGs, particularly in temporal bands with different distributions in the EEG bands for COVID patients. And then also, additionally, Shannon spectral entropy was higher and hemispheric connectivity lower for COVID patients. And it's sort of what I would expect. And I'm going to steal a punchline, but make this point that I think there's a consistency in the neuroimaging and the QEEG data. This is another analysis, and maybe some of you have seen this, a QEEG analysis of 20 post-COVID patients with comparison of baseline QEEG demonstrated increased theta and alpha activity, increased SMR at C4 compared to C3, and visibly increased in high beta and bilateral hemispheres. And this group, this was really a group of people in Poland that worked at a university. They were age matched to previous QEEG, and they had post-COVID symptomology. So is there a difference? Is there a test for long COVID? So I think that having a test would be actually really very helpful. You know, there's several possibilities as a cause of long COVID. You know, one is just acute damage that doesn't heal, like stroke. And I think some people have this, probably sequelae of COVID, but I think most of the research is really showing that there is at least some component of persistent viral infection. In previous studies in 2022 and 23, they were really showing maybe 5 to 15% of people had post-viral infection. In the last 6 months or so, we're really seeing evidence of maybe 40 to 60% of people continue to have evidence of viral infection. Another real important component to the pathology of long COVID is the half-life of the spike protein itself. And the spike protein has lasted up to 900 days. It's a tremendously long half-life for a protein to exist. And this has to do with the folding that it has. It makes alpha beta sheets, which makes it large and difficult for enzymes to digest. But even when the protein itself is cut into 6, 4 of those 6 pieces will form amyloid. They will self-bind. They will begin to bind other proteins in the body. So this is sufficient by itself, outside of persistent viral infection. Just the length of life, half-life of the spike protein is sufficient to cause disease. There are multiple papers out there that show that just having spike protein or even half of the spike protein present is sufficient to cause the weight loss, the inflammation, the blood clots outside of an active viral infection. So the spike protein is actually very, very toxic. The fourth possibility, and there's evidence for this as well, is persistent or permanent, semi-permanent changes in immune function, particularly in B cell populations. The B cells make antibodies, and some of them make active antibodies. Some of them make sort of auto-idiotype antibodies that inhibit other antibody formation, and this is imbalance. Antibody formation as a type of pathology is very evident. I did not put this paper on, it's worth mentioning, but they have actually identified autoantibodies to G-coupled proteins of receptors, which means that they are constitutively active, continually to be active, and are causing continued inflammatory signal. And these autoantibodies particularly are affecting the adrenergic system, the alpha and beta receptors that control the autoimmune function. And so they're an explanation and are causative of this phenomena where people have high heart rates, they appear to be anxious, they actually are preload dependent. That is, the effect on the autonomic nervous system is so significant that the body is not getting blood back to the heart, and thus the heart rate is increasing. And it's a very fatiguing effect. And I feel, others feel, this is what's behind this post-exertional malaise. Next slide. So what about, where else can we see that, as an explanation for what's going on? So transcriptomics is where they take cells and they are able to analyze all the RNA transcripts that are coming out of those cells to identify what's going on. And so in this study here, they identified, they were trying to make a biomarker or eventually an actual blood test to identify what's going on, to say that there's still, acute COVID or chronic COVID or long COVID. And so there's two factors that were identifiable, and that is continued SARS-CoV-2 antisense RNA, right? As well as another biomarker called FIN, which I'll get into a little bit here, sort of the neuroimaging to molecule. But really, we're beginning to have evidence that long COVID is infection that's not clearing. Next slide. And here's some of that data. And really, the figure on the left, the most significant figure that they see when they look at all these transcripts from COVID infection is a gene called FIN, which turns out to be a proto-oncogene. It's part of the tyrosine kinase pathway. There's about 80 of these. And then on the right, you can see that when you detect the virus using an antisense molecule in the red, and then add plus the blue, that when you put both of those together, you really get into this specific and sensitive level of what long COVID is. So here's really good evidence that RNA of the virus still exists. And when we pair it with one of the highly expressed transcripts, the FIN, you really have good evidence and a good test for long COVID. Next slide. So we have a possible explanation for long COVID: continued infection by SARS virus and increased FIN expression. So I wanted to spend a little bit of time about FIN because you could see from that last data that it was very highly expressed in COVID infection, and it might begin to explain some of this, phenomena that we're seeing in the brain and some of the behavior that we see from brain change. Next slide. So what is FIN? FIN is a proto-oncogene, a Sarc family tyrosine kinase. So this goes back to long history. Sarc family tyrosine kinases were identified based upon the infection of virus in chickens, and these would get constitutively active. All right. So this is a protein tyrosine kinase oncogene, and it encodes a transmembrane associated tyrosine kinase that is implicated in control of cell growth. And it is associated with several downstream markers of inflammatory pathways, including phosphatidylinositol-3 kinase. That's probably one of the best known ones. Next slide. And this right here is really a very deep paper that is really worth reading and investigating. And so these authors in 2021 were really sort of analyzing similar data. They were looking at infected cells and seeing if there was a relationship of infected cells with these other genes that were expressed. And they were really looking at these cells in Alzheimer's disease. Next slide. And so they looked at a large amount of genes, and they were looking again, they were doing a transcriptome analysis. And this is important to remember. This is 2 years before we're looking at genes to identify that are upregulated that are related to long COVID. And so there were several genes, and the IFITM3 gene and the FIN were overexpressed in 2 regions, and Alzheimer's in control, the temporal cortex and the perihippocampal cortex. Now, what? I think those are, I think a couple slides back, I think those are the same regions that were affected in long COVID and COVID, acute COVID. So, and I'll come to that, and you can tell me what you think. But it's important to see that this gene was identified by different groups several years apart, and they also looked at single cells to see if they were differentially expressed in Alzheimer's disease patients when compared to controls, and they are. Next slide. And here's, I put this in because they did something called a string analysis of these genes to implicate FIN and IFITM3. And it's just actually a really beautiful picture that shows these relationships of all these genes. So they're really putting these genes at the center of these interactions. They're main control genes. Next slide. But I think there's something called the simple test, which is if these genes are important, okay, you've identified them in long COVID, we've identified them in COVID and Alzheimer's, where are they active? And are they active in the same areas that we're seeing affected by hypomethylation? And when we look at PET scan, are they in the same areas where we look at temporal, anterior cingulate gyrus, perihippocampus? And the answer is yes. So I think these are pretty similar, and I think they pass the simple test. Complicated pathways, but they get to a simple answer. Next slide.
Hang on.
Okay.
I can't use my normal thing and advance the slides. It's giving me a rough time. Sorry about that. Sorry.
No,
Not
it's
sure what
okay.
happened here. Close pen. I don't know. I can't seem to get it to go forward. I'm sorry.
So I think the last slide is a summary slide, actually, and I can just speak through it. And that is to really say that we're having continued epidemic. We're having changes in the brain that are causing damage, affecting older people. We're clearly having changes in younger people, and it doesn't bode very well for the future, honestly. I think that there's good evidence that there's continued infection at low levels, and that even that continued infection is producing protein that's long-lived, and it's also leading to antibodies and changes in transcription and cell behavior that are Alzheimer's-like. So that's where I'm at right now. I think I would tell you, because people ask this, so like, what should we do? And there are ways of attenuating this inflammatory pathway and inflammation in general. And the probably the best one is to buffer the system with glutathione by giving either N-acetylcysteine or glutathione. And I'm actually having improvement with my patients with that. If people are having the sort of POTS-like syndrome or exertional fatigue, post-malaise fatigue, then I am giving them low-dose naltrexone, and I've had really remarkably good results with that. There's concern about continued lung function, and both sort of inhaled long-acting steroid that we give conventionally for asthma, as well as these, N-acetylcysteine and low-dose naltrexone. I've seen improvement in lung function with these cases as well. So I leave that with hope. My belief is the world's going to have to come to a better understanding and acceptance of continued infection and what it means. There's data out there that say if you've had COVID 3 times, your risk of long COVID is 40%. So I just leave that with you.
Wow.
So this is kind of technical and biochemical about the molecules, but I think the molecules are important. I think they're really reinforcing what's happening in the brain.
Some of it
Wow.
sounds similar to the 1918 virus in that there were infections for years, several years afterwards, continued to be, but the clotting was something that really horrified the physicians at the time. It was everywhere in all the organs, and they saw it. And so it sounds like that's an important factor, plus the inflammation. But you're saying in modern times we're identifying issues at a deeper level because we have the technology.
Yeah, the technology's improved really remarkably in the last several years. And of all the things that have been studied in the world, nothing's been more studied than COVID, frankly.
Wow.
Huge amounts of information on it. The influenza virus had, post-influenza syndrome. One of the pathologies of influenza was that it very commonly led to a secondary streptococcal infection, which led to something called DIC, disseminated intravascular coagulation. And that's particular to bacterial infections. And influenza also weakened the immune system, which led to that bacterial infection. So Barry's book, The Great Influenza, is really a tremendous resource for that. This virus.
Yeah, that's what I was referring to.
This virus, COVID, I have seen blood crystallize coming out of a patient. Just
wow.
Absolutely, it's very frightening, science fiction level fear. And it has to do with the spike protein. The part of the receptor binding domain binds heparin. So the spike protein is very coagulopathic, and that's also one of its pathologies.
In the brain, that's gonna wreak havoc because the brain is one of the organs that uses oxygen the most.
Yeah.
Right.
Yeah.
And that's going to result in a lot of damage because the brain depends on all of that fine capillary activity, and it has to sleep to clear it all out.
Yes.
And then you have the buildup of the inflammation, and you're saying there's there's a possibility of secondary bacterial activity or bacterial-like activity?
Well, that's true in influenza. I think there's a couple of things happening in the brain with COVID and post-COVID. I think there's clearly a global effect of inflammation and change throughout.
Yeah.
But I also think there's very specific portions of the brain that appear to be more affected. And I think that has to do with the location of the spin protein, honestly. And that bears out what's going to happen in the future.
Well, the dementia is largely a reaction of the immune system.
Yes.
The plaques and the tangles, and they
Yes.
form mostly in the temporal lobes and the prefrontal area. And you were saying, we were looking at the imaging of this, and there's a similar action, but is it a different type of process than that, or is there some similarity?
So what I would say is there's similarity in the paper about Fin and SARS and this IT3M membrane protein. He spent a good deal of time about it, and he calls it demi-infectious. He calls it demi-infectious. And by my understanding is he's like, look, the brain is having an inflammatory hit from a thing, in this case COVID, but that continues much like a fighter punching in the dark, right? Yeah. Think about a drunk man who's angered, who can't see, and is just swinging blindly. And there was at one time another fighter fighting that man, but that process, it just continues and perpetuates itself.
Sounds like it's a chain of different levels of immune response, and
yes,
and the most removed chain just continues on.
Well, my belief is from this data, there continues to be low virus amounts that are continuing to put out spike protein. And Rob shows that clearly, looking, where we see, where they are able to detect the RNA and the antisense level. And where that level is below detection, I think we clearly see the FYN gene being active. And I think the FYN gene is sort of a funnel where a lot of signal is coming to it, and so it's becoming active. It's kind of a bottleneck of signal transduction and inflammation. So where we may not see the antisense, we're below the level of detection, we're seeing its result, however, in the activity of the Fin gene. So those two by itself make a clear case for continued inflammation, and I think continued infection. It's almost like there are actually two fighters fighting in the dark, and the one that's drunk and sort of senseless is occasionally getting nipped and picked at by another fighter, but he's continuing to blast away in a destructive fashion, unable to get at this, this little thing that's present.
So James, if somebody were to have a disorder like an autoimmune disorder and gets COVID, that could really cause them some really long-term serious problems, can it?
Yes. And the autoimmune component of the virus is vast. So when they've calculated, sort of looked at the amino acid sequences in the virus and say, hey, how much of these amino acid sequences match what human protein production can be, it's about 2/3. So it's conceivable that 2/3 of the world could have an autoimmune illness from this.
Whoa.
Which, seems vast. And if you already have an autoimmune, you're already set up to have sort of B cell subsets to not function well. Yeah, it's truly going to be impactful. That's why I think young women are so impacted.
Yeah.
They tend to be more in the autoimmune affected category.
Yeah.
You know, and I think there's probably still some of the virus that's present. When people come to me, if I can treat them like, okay, I'm going to put you on Paxlovid for 5 days, and I'm going to buffer the inflammation with N-acetylcysteine, and then if I see some autoimmune symptoms, then I put people on low dose naltrexone. And I've had people who were in wheelchair, 10 months. Then in a month, they're out of their wheelchair.
Wow. I have a teacher, I'm taking a couple of courses, and she's very young, in her 20s, has rheumatoid arthritis, got COVID a month ago, and she just got through having the flu this week, and she was just a real mess. And I was saying, you really need to work at building your immune system.
Well, one of the key components of that is vitamin D.
Vitamin B.
Vitamin D3.
D3. D3, gotcha.
And that is, an antihistamine, and it clearly impacts the immune system. And she can take 50,000 units easily if she's not been taking any. She could easily take 50,000 units a day for a week, and then twice a week until she's done, 15 tablets. It would help her. It would reduce that, and she probably needs some frank prednisone.
In terms of the QEG, I mean, this all makes sense, especially if you follow an oxidative stress model, in that you would expect delta to show up, particularly in the temporal lobes and the frontal lobes. You would expect to see the MRI reflect that. They didn't mention that in the one study, but in several other studies that Rusty Turner showed us, he's a neurologist. They noted in all of them that they had a lot of delta and theta, which is what you would expect from the inflammation. And with that inflammation in those specific regions, you would expect this reduction in transmission velocity, especially long term, and people's reaction time would be reduced, which also was reported in these tests. So that's all consistent with the description of disease, that you would see those things both in terms of cognitive presentation and the QEG presentation. I would expect, of course, alpha to be high, because no doubt it would affect the thyroid balance in the body tremendously, because that's central to the immune function, and that would bring the alpha up, and the delta would be from the inflammation. And I also I did a QEG on myself right afterwards, and it was all temporal and frontal lobe delta. I had a little more slowing again in the alpha, and an increase in that brain fog, but I actually lost considerable cognitive function, and it taken a year back to get my speech recovered.
I have components of long COVID. I have tinnitus and some neuropathy in my feet and other things, and I take N-acetylcysteine for sure.
Yeah, we did. I mean, there was a lot of vitamin D stuff. I mean, I obviously loaded up on all that stuff. The doctor I was working with said, they said that, she said that she had a paper that showed that COVID particularly, it was didn't like ibuprofen, and it reduced inflammation. So I was taking ibuprofen. Of course, that's a danger to your stomach, but it seemed to help to some degree too. Probably there's something else better, but that's all we had at the time.
I've been from the beginning, a big proponent of indomethacin, also an anti-inflammatory, but in studies in the sort of the 1 milligram per kilogram amount, which we use for gout and easily prescribable and reasonably safe, it kills COVID in cells, and you could treat dogs with it, and they did a lot better. There were also studies from India that showed early treatment with indomethacin really resulted in vast reductions. Nobody wound up dying. Only a couple people needed to go to the hospital for oxygen. Vast superior outcomes versus Tylenol. And I used indomethacin and still do. Paxlovid's like $1,600. Some of my patients still have COVID. I treat them as quickly as I can, call out the medicine as quickly as I can in order to reduce the likelihood of the sequelae of the infection. So it still is something that we can use. The other component of COVID, after the 10 days, it's really a histaminergic mast cell-like disease, and that's what we see on the X-ray and CTs of the lungs. It's not pneumonia. It does not look like pneumonia. And if you use a strong antihistamine like cyproheptadine or promethazine, you could clear that. And I did do that to lots of my patients. And you could give dexamethasone, and between cyproheptadine and dexamethasone, Pulmicort, if they were wheezing, and inhaled steroid, their oxygen needs would come down in the severely sick. So there's a lot left. It really does create a lot of autoimmunity, and that's part of the issue.
So if our clients show symptoms of this, who would they be best referred to in terms of medical background? Given what you know.
There's a couple of things. I think if you don't have this in your own offices, I mean, you can call our office for sure. And I've taken calls from all over, and they're pretty effective. But if you can have in your own offices some supplement, you can have vitamin D and N-acetylcysteine, not expensive, very helpful. Glutathione, very helpful. But for the autoimmune components, I really haven't missed with very much with low dose naltrexone. And that's a Schedule 2. And so if people are having autoimmune, parts of the illness, they should find somebody with a license that can prescribe this. I've looked at some long COVID clinics. There's one in California. Low dose naltrexone is a mainstay, just a mainstay. So it's not a narcotic, but it's an antagonist to narcotics, and so it's a Schedule 2.
Well, that's good to know. All valuable information.
It is.
Can I ask a question?
Sure.
Please.
Hi, James. This is Bree Sebastian. I've
Uh-huh.
worked with you once before. Thanks for all this incredible knowledge. This is so prevalent. Do you use ivermectin? And if so, do you follow the FLCCC protocol? I'm aware that as an antiparasitic, I'm wondering if there are side effects from detoxing parasites while trying to kill spike protein. I've heard how effective it can be on spike protein, but I was wondering if you recommend it.
If people call and they want to try a round of ivermectin, I don't have a problem with that, and I've prescribed it. What happens with ivermectin is there's multiple mechanisms. Probably the best known is the inhibition of nuclear receptor 2 spike into the virus. I think that's, you know, where we're looking at really continued low-level infection. I think it's actually reasonable to try that and see what you see with that. I'd be curious, you know, I'd be curious for a test to see if it clears COVID, you know, antisense detection. I'd be curious if FYN would come down if we had a test for that. So,
I mean, I
and
can tell you that when I got COVID, I mean, it worked in practically 30 seconds. I mean, I was delirious. And when I finally reached for it, the symptoms were reduced radically to where I was functional again. And a few of my friends who, you know, just work in the medical industry, they and are fairly conservative, you know, they also have used it because they tried after about 5 days of COVID to treat it otherwise. And then sure enough, the same experience I had. The minute, you know, it just kind of, you know, found its way out much more quickly. I was just wondering about, you know, kind of more long-term effects. You know, because like I said, I don't know if you follow what's on the COVID critical care FLCCC website.
I've seen some of it.
Okay, yeah. I just really appreciate that they update it so much and they've got so many contributing doctors and yeah, so thanks.
All right. Well, James, incredible presentation. I hope you'll consider doing this at ISNR.
Okay.
Really, they just sent out another announcement. I'll forward that to you. I'd love to see you do at the conference this year. I've been encouraging people to really pay attention to COVID and especially long COVID. And this is such a beautiful, like, you know, presentation to at least get people thinking about it in the way you've gotten us thinking about it. So thank you so much.
You're welcome. It's a real disease. It's a real illness.
Yeah.
It really is.
Yeah, I know. It's scary. This is a bit scary looking at this, you know, especially for someone like me who hasn't had it yet.
Good for you.
Yeah, I'm one of the few people I know who hasn't had it. So, anywho, thank you so much, Richard, or anybody else want to say anything before we end?
I do have a question.
Yeah.
Do we know if these subjects had vaccinations or not prior to their COVID infection?
The answer is in the literature, they were not, right? So, you know, what we're having now is sort of a potpourri of infection and vaccination and then infection. It's hard to say. In these studies, they weren't compared to a vaccine group.
I have a question. Had you heard at all of using Zyrtec and Pepcid for the initial?
I have. That speaks to the histaminergic, second part of COVID. The first part is an active viral infection in which antivirals work in the first 8 to 10 days. The second, you know, part of that 10 days and after for the next several weeks is really more of a histaminergic type reaction, and it is responsive to antihistamines. And I have used antihistamines in that second component. I prefer cyproheptadine as it's very strong, and I clearly saw improvements in lung function and oxygenation with it.
Thanks.
All right. Okay, everybody. Thanks for attending. And James, thanks again so much for your time.
Yep.
We'll see you here, I guess, on Wednesday, everybody.
All right.
Wonderful presentation. I got so much from it. Thank you so much.
Thank you.
Okay. Bye, everybody.
Thank you. Bye-bye.
Bye.